My name is Wesley Lindsey. I'm here to talk to you about hypertension, and hopefully, at the end of this talk, you'll have some useful ideas for how you can, manage this in your own practice and know when to refer, and just in general, be more comfortable with this growing patient population. So let's see. First question, I guess, what is hypertension? Let's talk about that. You can read all 75 pages here if you'd like in the most recent guidelines from 2017. And they go through very in extensive detail about what it is and how to manage it and how to define it and all that. Important thing to know is that, there's basically two main categories. You're either greater than 13 years of age or you're between ages 1 and 13. We're not really going to talk about neonatal preemie hypertension at this time. Not the main focus of this talk. So between ages 1 and 13, you have four categories. You have normal blood pressure. You have elevated blood pressure, stage 1 and stage 2, and these are defined based on percentiles, and these are based on age. And if you look over on the right side, on the right column, let's see if I can do this here, cursor. Does that pull it up? I don't know if you can see it or not. But so if you look over here on the right column, you see normal blood pressure, elevated blood pressure, stage 1, stage 2 for greater than 13. Now these categories are going to more closely resemble what you would see in the adult world. Okay, so and why do we care? Well, that may not be necessary to answer since we're all here at 5:30 on a weekday to learn about it. So we obviously do care. But why do we care? Well, there's a lot of it out there. So, any elevated blood pressure reading in a boy, in pediatric age, you're going to see between 15 and 19%, girls between 7 and 12. For whatever reason, it's more likely in Hispanic and African Americans versus non-Hispanic whites. And there's just a lot of factors in that. I wouldn't put too much stock into some inherent difference that's causing it. But we just know that's there, and that points to some other issues like social determinants of health. You actually have the prevalence of confirmed hypertension is about 3.5%. And then the elevated blood pressure, which you formerly may recall as prehypertension, that prevalence is about 3.5% too. In overweight children, the prevalence ranges between 4 and 25%. And then in adults, that jumps up to 32.5 or 32.6. But out of those, a lot of them don't know it. Those are the ones where you get the family history and say, well, there's nothing wrong with me. Have you ever checked? No. So they're not aware. Other reasons why we care, well, we know that if you have hypertension in childhood, you have increased risk for elevated blood pressure in childhood, you have a risk for hypertension and metabolic syndrome in adulthood. This is a risk factor for early cardiovascular disease in adulthood. Some autopsy and imaging studies show there's evidence of blood pressure related damage in young people already. So you don't have to be, 40 years old to see these target organ effects. And then hypertension is often a marker of other disease processes, which we can get into a little bit more. So who's at risk for hypertension? And of course, the main ones that we think about here in our age group we're going to talk about, obesity and lifestyle. Those are some of the two main ones that we see. We see some kidney disease and thyroid disease, as well as congenital heart disease. We do have a one lesion that'll give you hypertension, and we can rule that out pretty quickly. But we've learned that our job is more expansive than that these days. Diabetes and certainly is associated with it. Prematurity, they can have hypertension, from the beginning, and they also are at risk for hypertension beyond a year of age and into adulthood. If you have poor sleep, obstructive sleep apnea, sleep disordered breathing, those sorts of things are risk factors for developing hypertension, certain medications that we treat patients with, especially the stimulant ADHD medications. And we talked a little bit about gender, race, and ethnicity. I think those tie right in with environment as well as potential risk factors. And then, of course, there's family history. It does tend to run in families. How does it show up? What's the presentation of hypertension? Well, it can look like anything. It can be the star athlete, it can be the, typical child, it can be the newborn in your office. Any of those can show up as hypertension. There's not one particular phenotype. What are some of the signs and symptoms? Well, the biggest one is actually not listed there because there aren't any most of the time. And so that would be the main one, is there aren't any signs and symptoms for most of it. But if it's severe, you might see neurological changes like headache and vision changes, and those are going to be sort of red flags. Go get evaluated quickly. Hematuria, and I have had one or two instances where optometrists have sent patients back to the pediatrician who wound up seeing me because they saw retinal changes in their exams. Um, Dizziness and fatigue, well, those are pretty broad. They can be associated with hypertension. They can be associated with a lot of other things too that aren't hypertension. And then on the far right column there, nosebleeds, chest pain, nausea, vomiting. If you've got hypertension that's leading to that, then it tends to be more severe. So that's sort of these are like the red flag warning signs and symptoms. What causes hypertension is elusive. In our age group, adults and anyone basically over 12, we think mostly of essential hypertension, which I tell people means essentially we don't know why your blood pressure is elevated. It just is. But when you deal with the younger children, and especially neonates, and excuse me, toddlers and young children, school age up to age 6, renal disease is actually going to be a lot more likely to occur. And they can have endocrine issues, coarctation of the aorta. Not every coarctation is an emergency right at the beginning. They can be sort of mild to medium coarctations that sort of have a slow burn, and you develop hypertension over time. And then they also can have essential hypertension. But you have to keep the other things further up on the list. Between 6 and 12, it's a little bit of a gray zone. That's also where you see a lot of the what we call iatrogenic illnesses, or stuff we do to patients, medicines we give them, can lead to that. And then by the time you hit 12, essential hypertension moves right to the top, and the other ones are still there, but we're thinking you're much more likely to be dealing with just plain old essential hypertension. So how do you diagnose it? Well, first you have to measure it, and blood pressure measurement is not as simple, I guess, as a lot of people think. You really need someone who's skilled at measuring it to get it right. There's the screening with the oscillatory blood pressure that we have in a lot of clinics, and those overestimate blood pressure a lot of times. But when you get a high blood pressure reading, it's important to confirm it with a auscultatory method. So get a sphygmomanometer, put your stethoscope on, try to check it 3 times if you can. I know you when you're seeing 60 patients in a day, that may not be feasible, so I get that. But certainly, if you have someone who's at risk, this is something you need to consider. The ambulatory blood pressure monitoring is what the 2017 guidelines really are encouraging everyone to get. It's a great thing, don't get me wrong. It's just not readily available everywhere. We have it and we can do it, but even, we don't have an infinite supply of it either. In They don't recommend every single person who walks in with one elevated blood pressure reading get it. But if you're having elevated blood pressure readings greater than the 90th percentile for a year, or if it's greater than the 95th percentile on 3 separate visits, not back to back to back, if you got high risk conditions, sort of like we were talking about, if you think they might have white coat hypertension, or children who have a coarctation, which by the time that's the issue, we'll be dealing with that in our clinic probably. I don't recommend using grandma's device to make the diagnosis. Now that's, it's kind of being cute, but a lot of people will use the wrist devices and one size fits all, but one size doesn't fit all, which we'll learn here in a minute. And then school data can be helpful sometimes, but I don't use it for diagnosis. I use it more for trending. I tell people there's really nothing normal about getting your blood pressure measured at school. If you're getting your blood pressure measured at school, you're in an unnatural environment. You're being pulled out of your class or you're going out of class. It's just it's not set up for optimum results, and so the data may not be as reliable. So best practices. Well, here's what we should do, right? So we need, and I'm sure this is totally feasible to all my busy pediatrician friends who are listening to this. You just have your patient seated in a quiet exam room with their back supported and their feet on their floor and uncrossed for 3 to 5 minutes. So just make sure all your patients do that. Make sure none of them are worried about the shots that they may be getting at their well child check. Their arm must be supported at heart height. No talking. Very important. Usually when we put the blood pressure cuff on, that's when a lot of our older children want to tell us about whatever cool things going on. So I'm being a little facetious here. The point is getting an accurate blood pressure reading in the general pediatric office and anywhere really can be quite a challenge. And so, you look down here, this is sort of what the guidelines envision for you having at the bottom for your blood pressure measurement, whereas the picture over on the right is more like reality, where you have someone coughing and wheezing next to you and you're worried about getting a shot. And it's no wonder that your blood pressure might be a little off. When you do that, you're going to, put the cuff a little bit above the antecubital fossa and make sure, when you're listening to it, that you squeeze most of y'all know this, you squeeze the cuff, inflate the cuff until you're 20 or 30 millimeters of mercury above the loss of a radial pulse. So, and then here's the thing with the NHANES study, when you look at, what size cuff does a child need, almost a third of the ones from age 9 to 11 are going to need an adult cuff. And where we measure, first we do couple measurements. One is from the acromion to the elbow, so you get the length here. All right. And then you're gonna measure the diameter, and you want that bladder to go around at least 80% of the diameter. You don't want the bladder going all the way around. You don't want it just covering the bicep. And so that's important. And you need the width of this the width of this cuff to be about 40-ish% of the length you measured from the acromion to the elbow. And some people are more precise about it than others, but really, so when you think about, blood pressure's easy, anybody could do it. It's a wonder anybody gets an accurate blood pressure reading, because this takes practice and repetition and diligence to do all those things and get repeatable, reliable numbers. But it's important to have a variety of cuff sizes, and it's important to remember that just because you have a child doesn't mean that they're not going to be using all sorts of adult cuffs, especially as our population, as we see more prevalence of obesity. All right, so this is a little bit bigger chart than what we showed before. If you're between ages 1 and 13, we have nomograms from that 2017 paper that give percentiles based on normal weight and then age and gender. And so if you're less than 90th percentile, you're normal. And then, between 90 and 95th percentile, we call it elevated. And then, 95th percentile up to the 95 plus 12. And these numbers are listed on the nomogram. That's going to be stage 1 hypertension. And then stage 2 will be above that 95 plus 12 millimeters of mercury, or 140 over 90, whichever one's lower. So, and for 13 years old and up, it's a little bit more simplified and more in line with the adult parameters, or at least the younger adult parameters. It changes in geriatric age, but this is more in line with what you'd see for standard 50-year-old patient. So the difference between the old classification and the new classification, the words pre-hypertension are illegal now, so I don't hear anybody saying that anymore, okay? Uh, the teenager and the adult criteria match very closely. And then the blood pressure values are for normal weight youth, so they don't add in the weight thing like they were before. So. All right. So is the blood pressure elevation or hypertension, is it primary or secondary? Primary hypertension, that's like we talked about earlier, that's the most likely thing you're going to have in teens and adults. Secondary hypertension, you're always thinking of it, and you're going to find it at some point. But again, remember, if you're less than 6, that's when you're most likely to find it. Over 6, it's becomes more unlikely. Renal disease, coarctation of the aorta, endocrine disorders. I still haven't found a pheochromocytoma. Uh, I really thought I would have found more of those by now. Neurofibromatosis, renal artery stenosis is associated with that. So that's something that you think about. We probably have a fair number of NF kids around here. And the mechanism for their hypertension is renal artery stenosis. Other medications, we talked about stimulants, but also the steroids we give kids for their asthma, Sudafed for their colds, and oral contraceptives for all kinds of reasons. So what do you do? What's the workup? Well, if you're over 6, you don't have to draw every lab and throw the kitchen sink at them, especially if they don't have a huge family history. I mean, if they do have a family history of hypertension, if they're overweight or obese, and then if they have an otherwise reassuring physical exam, in other words, they don't have proptosis, they don't have a renal bruit, you don't have to go ahead and order, aldosterone activity levels and whatnot on them. I do recommend that you check for protein in the urine with a UA. I do recommend, and well, not just me, the guidelines recommend checking for creatinine and electrolytes, and then a lipid profile. It's a different color because high cholesterol doesn't give you high blood pressure, but those two, like, they travel together. So there's a good chance if you got one, you may have the other. If you are overweight, then you may want to change that BMP to a CMP to get the liver enzymes in there as well, because non-alcoholic fatty liver disease. And then, of course, the hemoglobin A1C. Yes, we're not hepatologists or endocrinologists, but if you find these things, then we can get, you can get them referred to the other places that they may need to go. And then here's one that's a little controversial. The last one, ambulatory blood pressure monitor to confirm. Yes, that's the gold standard. We don't always get that because the devices just aren't that easy to obtain. If you've got things that make you think there's something else going on, you can consider other stuff like a thyroid, urine drug screen, renal aldosterone levels. Sleep study is a big one. If you got somebody who you think has really obstructed upper airways, get a sleep study, and then CBC for anemias and things like that, iron overload, hemochromatosis. So what do we do? Well, if we're going to start medical therapy, it's good practice to get an echo to look for LVH, and also to make sure we're not dealing with a coarctation. We try to calculate a LVMI, that's left ventricular mass index, and that we look for, if you see a greater than 51 grams per meter to the 2.7 power, you'll need your scientific calculator for that. But anyways, if you see that, that's what that's sort of one of the definitions for that. EKG is not such a great tool for figuring this part out. You can get a general idea for LVH in certain other conditions like hypertrophic cardiomyopathy and that sort of thing, but with essential hypertension, your EKG is not going to be super useful for that. We get echoes, we get echoes periodically every 6 to 12 months here if they have LVH that's persistent. Now, when do you work up someone for renal artery stenosis? Does everyone need a renal ultrasound and a CT scan of their renal arteries and that sort of thing? I don't do that really, unless we have hard to control blood pressure to start with. Okay. If you see hypokalemia on your basic metabolic panel, that's also could be a trigger for it. If their diastolic numbers really high and you're like, what's going on with that? That's something that those are sort of tip-offs for renal artery stenosis. Size discrepancy on renal ultrasound. Yeah, I usually don't get the renal ultrasound right away on every single person. So don't tell the guidelines people that. But there are not. It depends on other risk factors. If you hear an abdominal bruit, then yes. And then any high risk condition like these sort of things, neurofibromatosis, fibromuscular dysplasia. I misspelled fibromuscular. Sorry. Williams syndrome, Alagille's, Takayasu's arteritis, mid-aortic syndrome. These are all sort of things you may not run into on a day-to-day basis, but these are just the names of some of the high-risk conditions. And if anyone has questions about any of that, we can certainly get to it at the end here. So I keep sort of I've sort of like thrown shade at ambulatory blood pressure monitors twice now already, even though I really like them. They're now available here at our practice, with a consultation with us. Most of the devices that are out there, so if you just want to go buy one, they're not approved for children of all sizes, and so you would need an arsenal of multiple devices. We have multiple cuffs that go with ours. The interpretation takes training. Even if you ask our colleagues, a lot of them are like, no, we don't want to interpret this, and so we'll get consulted by our colleagues sometimes for this to understand it. But I guess the biggest thing is that the AAP, when they recommended it, I mean, yes, this is a really good thing, but it's something that's potentially not available for a big portion of the population. This one here that's sort of affordable, like $58 for this one. It's a one size cuff here. If you get something that's more that's going to give you this is an adult small cuff device here. This is Space Labs, I believe. Yeah. For $4,000, and they're even more than that. These are just sort of commercially available ones. And they can be quite pricey, and so that puts it out of range for a lot of people, and even like I said, even though we have them, we don't have 100 of them. We have a handful of them, and we divvy them out based on request and need and that sort of thing within the practice. um, so there. So what do you do? What's the initial treatment? Uh, well, as we know, diet and lifestyle is first and foremost. And I think really, it gets a bad rap in adults, but I think in kids, if you can get them to do it, I think my gut feeling is that you have the biggest chance of success in lowering blood pressure with dietary interventions with kids. Now, it's really hard, just like it is with adults, but I think especially if you can get them moving. Um, so 80% of kids who are between 12 and 19 have a poor diet. And that probably includes the kids that live at my house. Getting them to have adequate fruits and vegetables is a challenge. And then, for our non-fainters, this isn't the fainting talk here. So only 15% consume less than 1,500 grams of sodium per day. For our fainters, we recommend they consume a lot more than that, but they don't have hypertension. They have low blood pressure. Um, and then I'm surprised it says less than 50%. It's way less, I would think. Get the ideal amount of physical activity, and 30% of females. And you can get, though, my point is that you can get effective blood pressure control in about 50% or about half of these kids if you can get them to do it. That's the hard thing, if you can get the buy-in. I don't have a secret uh, for that, unfortunately. So what do we do? Well, you do diet stuff. Um, we have there's a collection of studies, on physical activity in adolescents, and you can expect to lower on an average your systolic blood pressure by about 6 to 7 millimeters of mercury if you can get them to do moderate, vigorous aerobic activity 3 to 5 times a week. With a with a in the pediatric blood pressure nomograms, if you ever get to looking at them, 7 milligrams or 7 millimeters of mercury, 6 millimeters of mercury is not insignificant. If you really truly have a decrease of that amount, you could get someone in from the stage 1 to the elevated blood pressure range. But I think that you can see bigger results than that in some people. That's just sort of the average there. Um, if there's obesity, of course, we recommend motivational interviewing, and we link them up with our nutritionist for that as well, and we try to bump them up. We say try to do an hour. Now, the hard thing about an hour of vigorous physical activity when you're obese is that it hurts and it's hard to do, and um, that one's really hard to get compliance on. I don't typically restrict them from sports. I know a lot of the referrals will come in, restricted from sports pending cardiology evaluation for blood pressure. And then, my thought is unless it's just really severely elevated blood pressure, okay, uncontrolled stage 2, whatever, I would restrict them from weightlifting. But anything that's like below that, I let them play because that's activity, and that's going to give them a chance, hopefully, to improve. So finally, we do use medicines for this, and if you fail diet and lifestyle intervention after 6 months, we start it. Anyone with stage 2 hypertension, if I really think they've got it, like if y'all send them in and they got stage 2 readings, and we get stage 2 readings, and it's not just an overwhelming case of white coat syndrome, then it's reasonable to start blood pressure medicine while you're doing the workup. And you can do that too, uh, as your comfort level dictates. But what I'd say is I recommend whatever you start with a low dose and work your way up. We don't have to emergently lower blood pressure, at least as an outpatient. If they need emergent lowering, they don't need to be outpatient. We advance the dose every couple weeks, and I have them come back to see me every 4 to 6 weeks for a face-to-face check-in. It my next, whatever my first drug is, and I'll tell you about that in a minute. My next drug is thiazide. That's usually number 2. So hydrochlorothiazide is number 2. I like ACE inhibitors, ARBs, calcium channel blockers. Thiazide can be a first line drug as well. I tend to use that more in younger patients with lung disease, but you can use it in anyone, and it has a modest lowering effect. The one thing I steer clear of, if I can, unless I'm going up to 3 or 4 agents, is beta blockers. There is the association with beta blockers and exacerbating asthma, but you also have to think about beta blockers have a lot of CNS effects and can lead to depression and that sort of thing. There's a note here in the guidelines about ACEs and ARBs being less effective in African Americans, but I still wouldn't shy away from using it because again, it's a social construct, the race here, and so there's other factors that may make these less effective, and so you can try them. I think and just you may want to lower your expectations, I guess, on how successful you're going to be with your first dose, but there's that note in the guidelines as well. So when do you refer? When do I refer to cardiology or anyone? The most important one on here is bullet point 1. That's when you think you need help. If you need help, you refer them, and we can help you. If you're getting 3 separate visits with stage 1 numbers, that's a reason to refer. Stage 2 numbers, that if you're getting those and you can't get anything but that in your office, I think that's reasonable to go ahead and refer them. And of course, you would want to. I encourage the folks here in Gainesville, most of them have my number, to call me if they really feel like they're symptomatic or urgent or whatever, so we can get them in, because you don't necessarily have them waiting 4 to 6 weeks for a non-urgent blood pressure consultation. If you're having a blood pressure gradient, so your systolic blood pressure in your right arm is more than 20 above your leg, and it's not because they're flexing or showing off or whatever, that would be an indication to go ahead and send them, because that would be our one chance to get that one cardiac thing, the coarctation that we're always looking for, and we love those. And then, of course, finally, if you have an abnormal cardiac exam, if you got abnormal cardiac exam and high blood pressure, just go ahead and send them, and we will certainly help unwind that and see what it is. So this is our our nomogram here, and I'm going to see. It's so small I can't read it on my screen on my display. Give me just one moment here. Um, so yeah, there's a QR code here to get to the actual article. If you have library access, you'll be able to get a full PDF of it. But I borrowed this to help us out here. But here's the encounter, right? You measure the blood pressure, and then here's your choices. Is it normal, elevated, stage 1, or stage 2? And then you can just go down from there, and I'll leave this up for a minute. If they're low risk, just fine. You're going to just see them back and check them again. That's it. That side's done. If your blood pressure is elevated, you don't have to pull the fire alarm just yet. Lifestyle changes, come back, see me in 6 months. That'll be a good recommended approach there. If they come back and see you and their blood pressure is normal, fantastic. We'll just go back to our regular yearly visits. If the blood pressure is high, well, now we got to figure out what's going on. Hey, did you try working out? Let's try that. Try eating some fruits and vegetables, changing diet up a little bit. Let's try that. Come back and see me. It says in 6 months, but maybe sooner if you want. And then normal or elevated. If they're elevated, then but we're not like in that stage 1 range. That's when an ambulatory blood pressure monitor can help you out. And then stage 1 hypertensive numbers, if you get one of those, right? So you come back and you say, all right, lifestyle changes. We're going to do I would like for you to move. I want you to change a little bit about what you're eating. Let's come back in 2 weeks. And if it's still elevated, right, then we're gonna do the same thing. We're gonna check for a coarctation with upper and lower, and then see them back in 3 months. And then stage 2, lifestyle changes, come back in a week. And if you're still elevated, you got to go see Dr. Wallace or myself or someone like that. All right. So, and that's sort of what we do. And here's who does it. Got all of us on here, at least two of us right here. And then we got our guys in Macon here, and then Dr. Maloney. She's in Stockbridge and Eagles Landing. Where's Dr. Suthar practice? What clinic is she in? I can't remember. But
Noonan and Marietta.
Noonan and Marietta. Thank
and
you.
And Billerica sometimes as well.
Okay. So we got that covered. And then we have Lisa and Robin, and they do Lawrenceville and sort of outside metro area as well. So there's that. And those are our core preventive providers. Now you can twist the arm for a lot of our other providers and have them see them too. And then if they can't handle, they'll send it to one of us. So these aren't the only ones that'll see your high blood pressure, but we're the backup for everyone else then. This is Laura Hamilton. She gets a page all to herself. She's our registered dietitian, and I send a lot of referrals to her. She provides telemedicine, telehealth, what have you, consultations with families and some motivational interviewing, and really works with helping to these kids to figure out, what's one change you could make. And one of our approach, by the way, we don't. A lot of kids are worried about seeing a dietitian because they feel like, man, they're going to put me on like a kale and rice diet or something, and I won't be able to eat anything that I love. We don't believe in food villains, as I call it. Every food fits. You can get nutrition from anything. The question really is, what's the balance like? So, we really strive to have, sure, if you like cookies, well, what's that going to look like fitting into the rest of your diet? You can't have the whole bag of cookies every week or every day. So anyway, that's just not getting into it too much, but that's sort of the approach we have, is we don't rip away all the good food that they love. We don't take their Takis away completely. We talk about limiting portions and servings and frequency and that sort of thing. So that's my little plug for that. And you can't get Laura though without coming through us. So don't get any ideas there. You gotta send you gotta send them to us, and we'll be glad to send them to her too if they'll agree to it. So we also provide the ambulatory blood pressure monitors. This is the space labs that we use, and of course we do echoes. We love those, and we'll be happy to do that if we feel like there's an indication for it when you refer them in. So I appreciate everybody's time, and I'll pause now.
All right, thanks so much, Dr. Lindsay. I'm going to now make it so anyone who would like to unmute themselves can do so. Just give me one moment and you guys will be able to unmute yourselves. All right. Now, if anyone would like to unmute themselves and ask a question, go ahead. And you can also ask questions in the chat box too.
I had a question about how many chances do you give them to like change diet and lifestyle before you say, okay, we really need to do something about it? Are you really just looking at the number to determine that, or does the amount of time that they spent at those high blood pressures make a difference?
Yeah, it's a good question. So it depends on what what numbers you're dealing with, right? So remember, if you're stage 2, you're seeing them back in a week and checking them again. And if they're still out of range, you're sending them. But if you're dealing more in that elevated stage 1 range, yeah, you really want to work on this for like 6 months with them, or encourage them to work on it. For 6 months, and the compliance is going to be variable, but I usually set the expectation up. I'm like, listen, we're going to do this. I usually see them back in 3 months, even for my lower one. If once they're referred to me, I usually see them back in 3 months to sort of check in and be like, hey, how's it going? Are we doing any kind of exercise? That sort of thing. But yeah, I think it's the 6 months is a pretty good marker for the elevated blood pressure in the stage 1.
Do you mind if I add a little something, Wes?
Yeah, you go for it.
Yeah, so I think the other piece to it, though, is, if there's any evidence of symptoms or secondary effect, right? So that might make me change my mind. I think the stage for the elevated blood pressures, similar to you, tend to drag my feet for as long as I can. I've had some patients even have dragged my feet with their blood pressures for up to a year, as long as I don't see any sign of secondary effect on their heart, and they're asymptomatic. But that will change if that comes into play as well. So. I think all of those things. It's not a one size fits all for everyone.
And the other risk factors too, if they have a higher risk condition, for sure. Anybody else? I just saw a flash up from chat in the chat. I can't read it. Dr.
It's the
Hanara
good Dr.
Sabino.
Yeah.
Oh my. Well, hello, friend. Says, how do you direct the thick muscular athlete, football linesman, about improving BP when recalcitrant to meds? That's a great question. We do see, when I think of a thick muscular athlete who has high blood pressure, one of the things I really want to know is what are they doing to get those thick muscles? And that not everybody who has thick muscles has hypertension. But some of our athletes do. And so, you know, when I talk about when I see that, I really want to start to dig in and say, are you taking supplements? Because it's not always anabolic steroids. Is this are you chugging pre-workout all the time and you're coming to see me after you've just had that? And I think that I see Robin chimed in with a good note there. Yeah, it is helpful to explain to them why you care about this, and if you explain to them like this blood pressure is not just a number that's making Dr. Lindsay nervous, this is a number that's actually potentially limiting your sports career, because if you do target organ damage, you're not going to be able to play as long if your kidneys and your brain are not functioning properly. That's a motivational interview technique that, you got to find what's important to kids, because the teenager doesn't care if their blood pressure's normal or abnormal. At least most of them don't. They want to know, can they do what they want to do? But finding out if there's any other secondary causes in those athletic folks who otherwise you would think wouldn't have hypertension is a good start. Let's see. I see. I'm gonna follow up with Dr. Sabino here. Do I recommend a better stimulant energy drinks? Yeah, not energy drinks as a workout. I don't recommend the as a pre-workout. A lot of those pre-workouts are just loaded with caffeine, and of course that makes my heart twitchy to think about it. So I don't usually recommend those at all. I don't restrict them from creatine if they're making sure they're hydrating enough. But I would say, a better stimulant. I'm not sure what that would be other than just being hydrated. That's actually the best stimulant if you're well hydrated. um, and we see I have a note from uh, Kimberly Hodge Spears. Does height percentile for a patient affect what blood pressure is considered normal for a pediatric patient? Yes, it does. And the only thing we took out really, or I didn't take it out, but the guidelines in 2017 took out the weight. So it's just they just assume normal, sort of average normal weight. But it goes by age, it goes by height and gender. So you got a boy chart, a girl chart, and then um, it goes by height and blood pressure there. So it it's a lot of papers. But they have go ahead.
No, there's one other question I saw from Susan Smiley. Did you pick that one up?
Oh, well, okay. Somebody highlighted it. Okay, good. Regarding ambulatory BP monitoring and suspected white coat syndrome in a teen, is it okay to have the BP checked at a fire department or similar location? That is great. We are, I just should have mentioned that we are big fans of fire department blood pressure checking. Those guys actually do a pretty good job of checking it. And so if that's the only place they can get it checked, it's good. I don't use it for diagnosis, but I find those to be fairly reliable blood pressure readings, at least around here. And I think most of those, when you can get them and they're in between calls and they're bored out of their minds, they don't mind helping you out with a blood pressure check. So that's a good idea. And I do encourage that sometimes with some of my patients who don't have other means to get it checked. All right. Do the blood pressure percentiles built into CHOA Epic take the height into consideration? I believe so. I don't know why they wouldn't. Yeah.
They do. They do.
Yeah.
They do. It automatically
Yeah.
maps that for us.
And then in primary care, we preach no creatine. Well, I don't advertise it. But if it's I always ask questions. And it depends on how much they're doing and what they're doing. And so what I find is that if I outlaw something like that, which has the potential to be okay, if I outlaw that with them, then I kind of lose credibility and it gets harder to get them to follow other things. And so I try to work with them. I don't put it out like, hey man, take all the creatine you want, because I mean certainly it does put a load on the kidneys, and there could be some effects there with that. So I would say you can continue preaching, Pat Musto, continue preaching no creatine if you want. It's fine with me. You can work it out with your patients on an individual basis also. Let's see. Dr. Sabino, I've had a ped nephro colleague recommend Omron. Do you recommend calibrating home BP in your clinic? I'm not sure what Omron BP cuff. Oh, okay. Yeah, the Omron BP cuff. I'm not familiar with that personally. I think that you kind of have to just know your patient. I mean, for some patients, that would be probably the right thing to do, and you'd have to sort of verify, have them check it, come back, compare it to what you have in clinic. Um, it's not unreasonable. As a general rule, though, I don't I don't use the home BP stuff for diagnosis. I will use it again for trending. For trending, I definitely will use it for trending.
Yeah. And I've definitely had patients that I've brought in for a nurse visit and told them to bring their home BP cup so I can get a sense of where they're running compared to our manual measurements. But again, that's for trending, not for diagnosis.
How is hypokalemia related to now you're going to ask me a nephrology question. It's from Nikita Rangwala. That's a great question. And Dr. Wallace probably knows the exact condition. But yeah, if you got hypokalemia, it means something's not working with those filters that you have down there. And so you think of hyperaldosteronism, I believe, and that can certainly be related to it. Phone a friend? Anybody want to answer this board question for me?
You're in the right ballpark. That is
Okay. It's like
Any other questions?
it's like attending rounds here, man.
I know, lightning rounds.
Nikita's bringing the heat. No more nephrology questions, okay? Anybody else?
Very good. Well, should I then go ahead and take over? Wonderful. So let me share my presentation. Let's see. Okay, present. Dismiss. All right, very good. So again, my name is Michelle Wallace, and I am one of the cardiologists with our preventive team, and I'm also the medical director for our preventive team. So I appreciate everyone's willingness to stay on the call with us up until 7 o'clock tonight and to try to get through some of this dyslipidemia stuff. Really, both of these talks could almost be an hour to two in themselves. So we're just going to try to do some high-level things. But my goals and objectives for you this evening are for you to understand the importance of addressing dyslipidemia in childhood, to know the current recommendations for screening, to know the recommended first-line therapies, and to be able to give your patients some non-pharmacologic options for management. So just a reminder that dyslipidemia is the abnormal elevation of lipids, right? So cholesterol and triglycerides in the blood. It's a significant risk factor for cardiovascular disease, even in children, and early detection and management can prevent long-term health issues. So why should we care as pediatricians? Well, we know that heart disease is the leading cause of death in the U.S., and that atherosclerosis is the pathologic basis for that. And when we look at some of the autopsy studies that exist, and we look at some of the longitudinal studies that exist, including like Bogalusa and the PDAY study, we know that the process of atherosclerosis begins in childhood, and we're even seeing some of the changes start as early as 2 years of age. And so we also know that the risk factors for atherosclerosis can be found in childhood and track into adulthood, and that there are interventions that exist for management of these risk factors. And so it really starts in our wheelhouse as pediatricians. So in terms of the basic lipid metabolism, so I'm not going to take you all the way back to biochemistry, but just recall that cholesterol and triglycerides are essential for cellular function and energy. We use cholesterol to build up our cell membranes, for hormone production, for bile acid synthesis, to help us digest fat, as well as vitamin D synthesis. And the lipoproteins are responsible for helping to transport the lipids in the water-soluble space. But one thing I did forget to mention is that the importance of triglycerides. So triglycerides are also important for calorie storage, and they provide us with a rapid source of energy. So we need all of these things for our basic functions. Types of dyslipidemia that exist. So there's hypercholesterolemia, hypertriglyceridemia, there's mixed dyslipidemia, and low HDL cholesterol. So where you have insufficient protective cholesterol levels, which would be your HDL cholesterol. And dyslipidemia can either be primary or secondary. So when we're talking about primary, we're talking about genetic causes. The one that we tend to talk the most about is familial hypercholesterolemia, but there are others that exist as well. And then when we talk about secondary causes, we're talking about lifestyle related things, but as well, we're also talking about like nephrotic disease. We're talking about endocrine disorders that can cause dyslipidemia, drugs. We can iatrogenically cause dyslipidemia with some of the medications, particularly thinking about some of the antipsychotics that are used. Liver disease can be associated with dyslipidemia, as well as some of our storage diseases. And always remember that anorexia as well present with dyslipidemia. So in terms of the guidelines, the most recent guidelines that we have for screening come from the 2011 Integrated Guidelines for Cardiovascular Health and Risk Reduction. And these guidelines were endorsed by the AAP. And the biggest change in those guidelines was the recommendation for universal screening for children from the age of 9 to 11 years, as well as from 17 to 21 years of age. And in between, targeted screening is recommended. So in the past, recall that we mostly followed targeted screening based on family history, as well as, if they had other risk factors such as diabetes, hypertension, obesity, or were smokers, then we would check the lipids at that point in time. But now we're recommending that all children have it between these age groups. And the reason being is that, one, family history can be very inconsistent. I think particularly being from the South and knowing how we tend to not share our family histories with each other. I don't know about other people's families, but in my family, a lot of things that's grown folks' business, and you don't need to know what my health problems are. So there's a lot that's unknown when a lot of people come into your office. There's also knowing that family history alone misses about 17 to 90% of children with dyslipidemia, with most studies suggesting somewhere between 30 to 60%. And our primary goal really is to capture those asymptomatic patients with familial hypercholesterolemia who are at greatest risk for having an early heart attack or stroke or coronary artery disease. And for a male, that's anyone that has a heart attack or a stroke or coronary artery disease prior to 55 years of age. And for a female, that's anyone that has those same things prior to 65 years of age. So we're really trying to, and if you have familial hypercholesterolemia, we can start seeing these things occur like in your 30s and 40s. So we're really trying to capture these patients and see if we can modify their risk factors prior to that age group. So some of the arguments against universal screening is that the guidelines will lead to increased statin use without knowledge of long-term effects of statins on patients and the disease burden, needle stick anxiety, no evidence of treating mild to moderate elevations of cholesterol leads to improvement in disease burden as an adult, false labeling, and cost. I think one of the things that we're moving away from, though, is the fact that we don't have knowledge of some of the longer term effects of statins on patients. The statins have been in play and use in pediatrics since the 1980s. So we have more experience with it and a lot of information about side effects and things. So we can reassure families with that. Yes, there's going to be a needle stick that's involved. Some people are able to do it with a finger prick in their office, at least get a baseline something, which can help a little bit with that. But there is some evidence that at least in treating patients who are at highest risk, particularly those with familial hypercholesterolemia, that we can make an improvement in their disease burden. And we'll talk a little bit more about that in a minute. So we're going to talk about it now. So the International Childhood Cardiovascular Cohort Consortium, or IC3, published a pooled analysis of 7 prospective cohort studies in Australia, Finland, and in the US, and it covered about 38,000 people. And they followed the participants who had cardiovascular risk factors measured in childhood over a 35-year period and evaluated the association of childhood measures with subsequent development of cardiovascular events in adulthood. And what they showed was that the levels of cardiovascular risk factors in childhood, so between the ages of 3 and 19, were highly associated with fatal cardiovascular events in adulthood. So again, it makes an argument that we as pediatricians should be involved. And then the graph underneath comes from an observational study that was done at the University of Amsterdam. So these were patients that were that had FH. that were previously enrolled in a study for pravastatin. And they followed these patients for a mean of 18 years. I think it ranged between like 10 to 21 years that these patients were followed. And they compared the patients who had FH to their parents who also had FH but did not have statins available to them in their childhood years. And as you can see, there's a significant difference in terms of the number of events that occurred. So their parents were certainly having events much earlier than patients who had FH that started treatment in childhood. So again, an argument to screen and try to make a difference in these patients' lives, or maybe saving a lot of hospital cost and in some cases funeral cost, right, with treating at an earlier age. So let's talk a little bit about screening and lab interpretation. So the guidelines recommend that we check again between 9 and 11 and 17 to 21. It's up to you if you want to start with a non-fasting or a fasting panel. If you're using a non-fasting panel, keep in mind that triglycerides can be significantly affected by that. So you probably aren't going to get accurate readings for triglycerides with a non-fasting panel. However, what is consistent is the non-HDL level. So that's really just the total cholesterol minus your HDL cholesterol. And that gives you a sense of all of the atherogenic particles that exist in the blood. And if they're elevated, then it's worthwhile to go back and if that non-HDL is elevated, it's worthwhile to go back and complete a fasting panel in order to confirm the diagnosis. But if you have a fasting panel that is abnormal, it's recommended that you repeat it a second time, at least 2 weeks apart, but no greater than 3 months apart, and average the numbers. And if the numbers are elevated, then we start to go down the pathway of trying to treat and manage this, as well as work it up a little bit more. So what are the recommended cut points for children and adolescents? So there's some, for most of the patient population that you and I will see, we're trying to capture those patients that have total cholesterols greater than 200, LDL cholesterol greater than 130, non-HDL cholesterol greater than 145, triglycerides, if they're 0 to 9 years of age, greater than 100, and if they're greater than 10 years of age, then 10 years of age or greater than 130. And then we also want to have their HDL level, or their good cholesterol, or their protective cholesterol level, to be greater than 40. So should you refer? Well, if you're noticing a LDL that's greater than 250 or triglycerides greater than 500, please refer right away. These are patients that we have a higher suspicion for familial dyslipidemia in. Still could be some secondary stuff going on there as well, but there's a higher suspicion for familial dyslipidemia, and they should be referred into our office. When you have an LDL cholesterol greater than 190, there's an 80% probability that you have FH. So again, a reason to be referred in. And if you have a triglyceride level greater than 500, when fasting, it predicts a non-fasting level of probably around 1,000 or so, which increases your risk of pancreatitis. So those patients also need to be referred in. And if you have a patient that has a non-HDL greater than 190, you should suspect familial dyslipidemia as well. And we need to implement aggressive treatment. So those patients should be referred to our office. But in either case, whether they come to our office or they have lower levels and you're managing them in your office, we should again consider secondary causes of dyslipidemia. So I'm not going to go through all of this, but just put this up as a reminder to consider secondary causes. So in terms of management, well, first line therapy for everyone is going to be lifestyle changes. It's recommended that children receive at least an hour of moderate to vigorous activity per day, with at least 3 days per week consisting of vigorous activity. And it's also recommended that we cut screen time to 1 to 2 hours per day or less. When we think about the impact of exercise on lipids, particularly when we think about triglycerides, right? Because of most of our patients that are coming in that have obesity-related dyslipidemia, a lot of times it's high triglycerides and low HDL. And exercise alone alone can lower triglycerides by 30 to 40% and increase your HDL by 5 to 8 milligrams per deciliter. So it's worthwhile to invest in talking about exercise and what your patients and their families, because it's easier to do when you're doing it as a family than individually, investing in what the family can do to increase activity for the child and for themselves. So diet recommendations in hypercholesterolemia. So one of the main things is to decrease saturated fat sources. So we're thinking about butter, we're thinking about red meat. One thing that a lot of patients come in and they think that they're making the right decision is in using coconut oil. But coconut oil, although it sounds like it should be a healthy oil, has about 86 to 92% saturated fat. So I try to steer patients away from coconut oil and some of the cheeses that exist as well. I also try to encourage them to stay away from trans fat sources. So a lot of the oils that are used at fast food restaurants or the old school Crisco that I know my grandmother used to make a lot of delicious treats with. So I'm trying to stay away from that. And this is not an endorsement of Crisco in any way. So that's why I have it marked out on that. But that type of oil we should stay away from. We should increase monounsaturated fat sources, so plant-based liquid oils such as peanut oil or olive oil or canola oil. We should also try to increase polyunsaturated fat sources. So some good sources would be like salmon or sunflower oil or tofu. We also are trying to increase the fiber in the diet. So thinking about beans and legumes, vegetables, like green leafy vegetables, brown rice, potatoes, particularly the skin from potatoes is actually contains a lot of nutrients in it. Oatmeal is a good source of fiber, as well as just good old fruits like berries. So in terms of hypertriglyceridemia, diet recommendations there include decreasing the simple carbohydrates in the diet. So remember that excess carbohydrates are converted into glucose, which is stored as triglycerides. So you can increase your triglyceride level with carbohydrates. So we tell all patients to try to cut back on the simple sugars in their diet. And if they're going to have sugar, let it be more complex things that are coming from fruits and vegetables. It's also recommended that we increase the omega-3 fatty acid rich food in the diet. So everyone talks about salmon and tuna. Those are very dense in terms of omega-3 fatty acids. But another option that I give patients is trout. A lot of my patients also like to eat shrimp. I show them a chart that has the omega-3 fatty acid contents of different foods. And we recognize that shrimp does not, well, it has some, it does not have as much as a lot of your fatty fish do. So I try to encourage fatty fish if they're willing to eat fish. But there are a lot of patients that don't like fish. And so in those cases, I try to encourage that they consider like adding walnuts to the diet and like a trail mix. They also can consider flaxseed, chia seeds. You can also think about avocados. They're a good source of omega-3 fatty acids, as well as edamame. So in terms of pharmacologic therapy, who should receive therapy? So definitely the patients that have LDL cholesterols that have been confirmed to be greater than 190 milligrams per deciliter. Again, you're more concerned about familial hypercholesterolemia in these patients. The others, you may consider treating for lower levels based on the family history and whether or not they have risk factors or high-risk conditions that coexist. For triglycerides, we're treating patients again that have triglyceride levels greater than 500. And we may consider treating at lower levels, like for greater than 200, if their non-HDL is greater than 145. Again, those we're considering the fact that they have more atherogenic particles in their blood, with the non-HDL being that elevated. And so we're going to start to think about therapies there. So here's just a list of some of the special risk conditions to think about. So our patients that have Kawasaki disease with regressed coronary aneurysms, or if they still have coronary aneurysms, we're concerned about those patients. Patients with nephrotic syndrome, HIV, chronic inflammatory diseases, diabetes, chronic kidney disease, and in cardiology, we're definitely following these in our patients that have heart transplants because they're at higher risk for vasculitis and vasculopathy, excuse me. So in terms of treating hypercholesterolemia, first-line therapy for lowering LDL is statins. And the mechanism is that it competitively inhibits cholesterol synthesis and increases the LDL clearance via receptors. Again, these were first introduced in the 1980s with the first FDA-approved statin for children being lovastatin. So we have good experience with this. It's contraindicated in patients with liver disease, pregnancy, although there's more data that's come out now that's to suggest that statins probably do not have the effect on pregnancy in terms of teratogenicity that we have thought in the past. And so in the future, there may be some changes in the labeling regarding that. But for right now, it's still labeled as avoid in pregnancy, as well as if you have renal dysfunction. We take precaution when they're taking certain medications, such as some fibrates, niacin, and cyclosporin. And we're monitoring for signs of rhabdomyolysis, elevations in their LFTs. We're going to get into that a little bit more. We're monitoring it, but we're not monitoring as closely as we used to in the past. And when we're starting therapies, we're again starting at the lowest dose and increasing at least every 3 months to goal, 2 to 3 months to goal. There is no weight-based dosing for statins. We're starting at a dose and then doubling it if we're not getting the results that we want. So some of the other therapies that exist for managing cholesterol include bile acid sequestrant. So those were some of the first things that we used in pediatrics, but they have a lot of GI side effects, so we tend to steer away from them. And you also don't get as much bang for your buck in terms of LDL lowering. When you really look at this list, the greatest bang for your buck comes from statins, and so that's why we tend to use it. But recognize that not all statins are created equal. So based on the dosing of the statins or the dose of statin that you use, you may get less LDL lowering effect. So for instance, starting out with lovastatin at 20 milligrams, you can expect that you're only going to decrease your LDL level by about 30%. Now, if that's your goal, that's fine. Start there, and you may start there and stay there. Excuse me, but you may need to use higher doses. But I think it's always worthwhile to start, make sure the patient tolerates the statin first, and then work your way up. But set your expectations appropriately for the dose of medication that you're using. So, some other notes on statins. So in terms of when you can start statins, pitavastatin, pravastatin, and rosuvastatin all have FDA approval for heterozygous familial hypercholesterolemia for those as young as 8 years of age. Rosuvastatin, if you have homozygous familial hypercholesterolemia, is approved, for those as young as 7 years of age. That's a more recent change for them. But all of the rest of the statins are really only approved for those greater than 10 years of age. And that's just because that's the age group that they included in their studies. There's nothing really truly scientific about that. None of the statins, though, were studied in patients that did not have FH. So all the dosing recommendations are based on patients that either have heterozygous or homozygous familial hypercholesterolemia. And when we start statins, we have to be mindful of the interactions, particularly between some of the statins like simvastatin and lovastatin that require cytochrome P450. I'm taking it back again to pathology or pathophysiology and biochemistry, right, in terms of metabolism. And being mindful of some of the medications that we use frequently in pediatrics, such as erythromycin, some of the antifungals that can interact and cause higher levels of the statin in the blood and place patients at greater risk for muscle complications. Another thing that exists out there that we talk about grapefruit juice. So you may have heard people talk about grapefruit juice in the past and taking statins to avoid it. But really, in order to have that effect, you need to drink about a quart of grapefruit juice a day. So if your patient's drinking about a quart, then yes, definitely, you might want to be mindful of the statin that you're using. But if they're not, if they're just having a cup here and there, then the statins should be well tolerated with drinking grapefruit juice. And so some other concerns that exist with statins, right? So these are some of the things that our patients' parents are bringing up to us. So the liver and muscle concerns. So there have been studies done in children that show that there's a really low risk of serious liver toxicity with use of statins. There may be some mild enzyme elevations, but they typically normalize when stopping the statins, and rarely does it reach the threshold of being like greater than 3 to 5 times your baseline level. So that is something that we can relate to our parents and put them a little bit more at ease. In terms of muscle effects, myopathy is rare. It occurs in less than 0.1% of patients on statins. And there have been no identified pediatric cases of rhabdomyolysis attributed to statins alone. Most of the muscle symptoms that do, so more so myalgia than anything, those tend to resolve with discontinuation of the statin if need be. In terms of growth and development, studies have confirmed that statins don't affect growth velocity, cognitive function, sexual maturation, or hormone levels when started even as early as age 2. And then other things that we have to consider is that there's a low risk for diabetes in children. There is a risk, so it's worthwhile periodically checking a hemoglobin A1C while patients are on statins, but overall the risk for that is low. And then we also have to talk about mild side effects that can occur in terms of digestive issues and headaches, but those typically resolve with continued use of the medication, and so you don't have to stop the medication right away. So in the past, we would say, check an AST, check an ALT, check a total CK prior to therapy, and then every so many months you should recheck all of those levels again. And we recently, I guess that's over 13 years now, not recently anymore, but 13 years ago we stopped that practice, and the statin labels actually now no longer recommend that you check LFTs every 6 to 12 months. However, I think it's reasonable to check a baseline level, and most of the time you're checking this anyway when you're working up for secondary causes of dyslipidemia. You're checking a CMP in there, so check it, and then only recheck it if there are clinical symptoms that make you concerned about liver failure. Same thing for CK. If there are concerning muscle symptoms, then check it. But if patients aren't having muscle symptoms, there's no indication to repeatedly check it over and over again each year. So I just want to touch base or talk a little bit about some of the additional medications that exist for patients, particularly that have familial hypercholesterolemia. So you may have heard of ezetimibe or Zetia. It blocks cholesterol absorption in the intestines and can lower LDL cholesterol by 15 to 20% alone. And if you add a statin on, it can lower levels up to about 60%, depending on the statin that you use. It's approved for patients that are over greater than or equal to 10 years of age if they have FH, and is administered on a daily basis in a tablet form. It's ideal for patients that aren't reaching their targets with a statin alone. So frequently we'll add it on to their therapy. But also there's some patients that will use it and that have statin intolerance, or there's a strong family history of statin intolerance. Then families may be a little bit more open to starting ezetimibe over starting a statin, and so we'll use it in that case. But it tends to be well tolerated with minimal side effects. And then another therapy that's out there is PCSK9 inhibitors. Again, this isn't something that we're using in most of our patients that are coming in with obesity and such. These are patients that have familial hypercholesterolemia that we're using this in. But it lowers LDL cholesterol levels by inhibiting PCSK9. And so when PCSK9 combines with an LDL receptor, it increases the degradation of LDL receptors within the liver, excuse me. And when you have a PCSK9 inhibitor on board, it increases the clearance by increasing the number of receptors that exist in the liver for LDL cholesterol. Right now, it's approved only as an adjunct treatment for to statins for patients that have heterozygous or homozygous familial hypercholesterolemia. And it's ideal for those that are at high risk that aren't responding to your traditional treatments. There are two that exist that are approved in children, evolocumab as well as alirocumab. Oh my goodness. or Prialet, excuse me, that's given as an injection every 2 to 4 weeks. And so we have to, and we monitor levels. But these agents can lower LDL cholesterol by 50 to 60%, increase your HDL cholesterol by 5 to 10%, and reduce triglycerides by 10 to 15%. So they're pretty potent. And then additional management options for FH include lipid apheresis and liver transplant. But really, with the existence of some of the adjunct therapies that we have now, these are used less frequently. It's very rare that we're referring patients for apheresis, which requires, similar to dialysis, frequent trips to a center to have your blood basically taken out, filtered, and put back in, right? Or your plasma taken out, filtered, and put back in. So there's so that's a big burden on the family. Many are choosing to use like PCSK9 inhibitors every couple of weeks, which is less of a burden on the family and gets the same amount of lowering of your cholesterol levels. For triglycerides, it really depends. There's on how we're going to approach this. So if they have mild to moderate elevations, right, like that are in the 250 to 500 range, right? Really, our goal is to prevent atherosclerosis. These are the patients that we're more so concerned about the fact that their VLDL levels are going to be high. That can translate ultimately into elevated LDL levels and put them at higher risk for atherosclerosis. And so we may choose to use statins in these patients to lower their triglyceride levels. But be clear that a majority of patients that have high triglycerides are obese and have more of a mixed pattern where they have low HDL and high triglycerides, and a majority of them will actually respond to diet and exercise changes alone. It's very rare that we're thinking about therapy in these patients. We will consider, a lot of times we'll tell them to increase the omega-3 fatty acid sources in their diet, but there also exist prescription omega-3 fatty acids. However, none of these have been approved for use in children, so you're using them off-label if you choose to use them. For severe triglyceride elevation, really the goal is to prevent pancreatitis. And so management primarily involves diet modification, particularly if you're talking about a patient that has, for instance, like familial hyperchylomicronemia, right, syndrome. We're really trying to lower the amount of fat that they have in their diet, trying to get it down to like 10%, right, of their total daily intake. And so for these patients, you may consider fibrates, you may consider omega-3 therapies, but if you're adding in omega-3 therapies, you have to also keep in mind that that's part of their fat intake that they're taking in for the day as well. Again, the focus more is on diet there, but we may use them in that case. So just again, briefly about the omega-3 fatty acid supplements. And what we're really looking for is to try to, what's really helpful in lowering the triglyceride levels are specific types of omega-3 fatty acids, in particular DHA and EPA, which decrease the hepatic fatty acid synthesis and triglyceride synthesis and enhance fatty acid degradation and oxidation, subsequently reducing VLDL cholesterol release. There are two that are currently FDA approved for use in adults. There's no dosing recommendations in children. Some people will choose to buy over-the-counter supplements in terms of like fish oil supplements, but keep in mind that not all fish oils are created equal. And frequently they will contain omega-3 fatty acids that are not as helpful in lowering the triglycerides. So when patients are choosing to buy over-the-counter things, tell them to look at the back of the label and see how much DHA and EPA are specifically listed. Sometimes they'll just have a asterisk on the bottle, which tells you that it doesn't have that much of it in there. So be mindful of that. Other therapies for triglycerides, fibrates, and niacin, again, not approved for children and with dyslipidemia. There are no dosing recommendations for it. So overall, our goal is to get the LDL cholesterol less than 130 and triglycerides less than 100 or 130 based on your age. And I wanted to take a brief moment just to talk about LP little a, because it's making the news a lot lately. We're seeing a lot of commercials that are encouraging families to, particularly African American families, to have their LP little a's checked. And so we're starting to see more patients with elevated LP little a come into our office, and being asked about what to do in this case. So just as a reminder, the LP little a has a structure similar to LDL, but it has an extra apolipoprotein, or called apolipoprotein A, that's attached and makes it more atherogenic. And these levels are genetically determined. So this isn't something that we're expecting to change over the course of a patient's lifetime. If you check a level now, it's probably going to be pretty consistent as they go through their adult years. But we know that it's an independent risk factor for cardiovascular disease, affecting approximately 1 in 5 people. So a lot of people have elevated LP little a's. And in terms of children and screening, there's no official screening recommendations at this point for children. But we do consider it in certain populations. So one, if a parent comes in and says, hey, I have an elevated LP little a, and my cardiologist wanted me to make you aware, I'm checking the children for elevated LP little a as well. Patients that have familial hypercholesterolemia, we are checking it in those cases, as well as patients that have a family history of early cardiovascular disease. Again, males who have heart attacks or strokes and they're under 55 years of age, females who have had heart attacks or strokes within the family and they're less than 65 years of age, then we're checking it in those cases as well, particularly their first degree relatives of the patient. But the frustrating part is that we're checking it. We can know if it's elevated. We know that it's a risk factor, but we really don't have any therapy to treat it at this point in time. There were some studies about using niacin in the past. There's a lot of side effects, again, for using niacin. There's no recommended dosing in children. There can be some lowering of the number with niacin. However, there hasn't been any demonstration of long-term impact on CV disease to make a recommendation to utilize it to treat LP little a at this point in time. So what do we do with this number when we see it? We then look at all the other risk factors and we double down on making sure that those levels are normal and as low as possible. So we're encouraging lots of exercise. We're talking about smoking cessation. We are talking about the diet, good management of your diabetes, if you have it, management of your blood pressure. And then if you have elevated LDL cholesterol, those are the patients that I'm going to be more aggressive in treating their LDL and trying to keep it in the normal range. So that was just a little quick and dirty on LP little a, since it's coming up more in popular culture now. So in summary, early identification of dyslipidemia is crucial. Don't forget the universal screening guidelines. We're really trying to find these patients that have FH, and there are more out there than we are aware of. We need to remember that lifestyle modification is first-line therapy. Pharmacologic therapy is next, and should be used in severe cases. And it's really important that we consider multidisciplinary care. So in our program, as Wes mentioned, these are our wonderful preventive providers, our doctors, our nurse practitioners that we're all very proud of, some of who are on the call today. I did see that Robin is on the call today. Our nutritionist, who Wes mentioned, is able to provide telemedicine services. But we also have genetic counseling, which is helpful for our patients with dyslipidemia that we think is more familial in nature. So we have 2 genetic counselors in our practice, and they also offer telemedicine services. So with that being said, I'm going to stop. I know we have a few minutes to take some questions, so I'm going to open the floor for questions, and thank you for your time.
There's one in the chat that I can see from Richard.
Okay. So for obesity and FH and lifestyle failed, would you start a GLP-1 for greater than 12 first? Greater than, Richard, can you come off of, are you saying greater than 12 years of age?
That's how I took it.
Okay, all right. Well, assuming that's the case, I think that's a reasonable, okay, very good. Thank you, Richard. I think that's a reasonable approach. I mean, wait, you're saying obesity and FH. If they have FH, for clarity, we're treating with therapy, right? So we're talking about using statins for those patients because we need to get their cholesterol levels down, and their cholesterol levels are not going to be lowered by just diet and lifestyle alone. So if you're taking FH out of the picture and you're saying you have a patient that has obesity and they have dyslipidemia, then yes, I think it's reasonable to work on lifestyle things to try to manage their obesity, because I've had some patients that with that alone, and normally that comes with some other lifestyle changes that they're making. It's not just the medication alone, but it's medication plus lifestyle. Then we're able to see that their numbers have come down as well. So I think it's reasonable to start with that first, because my suspicion that they're going to have a heart attack or a stroke in their 30s and 40s is a little bit lower, right? And if they're homozygotes, I'm worried about, for FH, I'm worried about them having things earlier. But these aren't the patients that are in that category. So I think it's reasonable to start there first. Other questions?
I saw another question come in the Q&A section from Michael
Okay.
Tim. He asked, what do you recommend for low HDL?
So there's really no medical therapy for that, primarily recommending exercise. So exercise is what the main thing that we have shown to increase HDL levels, but there's no medical therapy for that at this point in time. There have been some things tested in the past, but they have not panned out in terms of impacting long-term cardiovascular outcomes. So for clarity, there have been things that have been researched in the past, but there's nothing that exists right now on the market to actually to treat it. Okay, I think another. Thank you, Dr. Sabino. He's going to keep an eye out for utility of newer adult meds. Yes, as well. Please do so. There's a lot coming down the pipeline.
Yeah, there's one that's going into like phase 2 or 3. I can't remember. That's about all I know about it.
Yeah. So there's lots of things. It's a rapidly expanding field. So.
And our nurse practitioner, Robin, just chimed in too. Instead of taking away all the bad foods right away in our diet and exercise talks, it's good to suggest adding in healthy foods to be positive.
Exactly.
That's right. No food villains.
Yeah, exactly. Any other questions?
All right, let me go ahead and share. Doctors Lindsey and Wallace, thank you so much for these great talks. Here is the course evaluation QR code. So don't forget, it's been posted in the chat box as well, but you have to sign in and complete this course evaluation to get the CME credit. There will also be, I saw this question come through, the slide decks will go out. And then they also have posted links to one of the algorithms as well in the chat box. So if you haven't gone through the chat box, there's lots of good stuff in there.
I'll go ahead and repost the blood pressure guidelines as well.
Okay. Thank you. Any other last minute questions or burning desires? And also don't forget in the evaluations or in the chat box, if you have any requests on future topics for these webinars, we are open to hearing what you guys would like to hear. All right.
There resources for nutrition, because obviously that's probably one of the biggest challenges in outpatient peds. You say, hey, we need to make these lifestyle changes and maybe you try changing these things. I agree. The food villain thing doesn't work at all. We've had actually a couple of other patients that refused to go back to the Strong for Life program because it was way too strict for them. And so, just in moderation, but maybe do you all have like a handout with suggestions, something that we could use as a jump off tool?
Yes, we have handouts for diet and exercise recommendations for triglycerides, for LDL cholesterol. We have things for hypertension as well. There are also another good source of handouts, some of which we use in our practice as well, come from the National Lipid Association. They have some great handouts there as well for patients. So we do have those that we are able to hand out, and I'm pretty sure we can probably. Jack, are we able to get some to people if they would like some copies?
Yes, I can attach that to, I'll be sending everyone who attended today an email with the slide decks, the BP guidelines, and I will include that as well.
Thank you.
All right. Well, thank you guys so much for joining. Thank you, Dr. Wallace. Thank you, Dr. Lindsey. We hope everyone got a lot out of this, and you'll be hearing from us when the next webinar comes around in a few months. Everyone have a great night.
Good
Thanks,
night.
everybody.
Thank you so much.